Okay, so this is Chapter 39, Nursing Care of Patients with Endocrine Disorders and ATI. This is Chapter 75 through 77 in your Med-Surg text. This starts on page 885. So in this lecture, I'm going to go over disorders that are caused by variations in the hormones of the pituitary, thyroid, parathyroid, adrenal glands. And as always, we'll talk a little bit about pathophysiology, etiology of each of these disorders, and then signs and symptoms and therapeutic interventions for each of them, and then talk a little bit about data collection and assessment along with the nursing care and interventions as well. So disorders of the endocrine system are usually caused either by too much hormone or too little. If too little hormone is available, then it causes, this can be caused by like hypofunction of the gland or from insensitivity of the hormone's target tissues. Too much can be caused by a hyperactive gland from hormones being secreted or from hormones being secreted from other sites than the gland itself where it would normally be found. And this is called ectopic hormone production. It can also be caused by other medications with, other medications like with hormone replacement. These can all be primary disorders, which involve problems with the gland itself, like with the thyroid gland being diseased and causing hypothyroidism, or they can be secondary where the problem is caused outside of the gland. So here, like if the pituitary gland is not secreting thyroid stimulating hormone, then there would be hypothyroidism, but the problem is not with the gland itself. The problem would be with the pituitary gland. So that would be a secondary type of issue. There are tertiary issues as well, which would be problems with the hypothalamus. So first let's take a look at disorders caused by imbalances of the pituitary hormones. First we'll look at antidiuretic hormone. Remember that antidiuretic hormone increases water reabsorption by the kidney tubules, returning water to the blood. If too little ADH is secreted, then the person will have diabetes insipidus and experience water loss. And with too much ADH, the opposite will occur, causing water retention. And this order is called SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. With diabetes insipidus, there is an insufficient amount of antidiuretic hormone or ADH, which prevents adequate reabsorption of water, and that then leads to diuresis. So these patients can urinate, just buckets full, so like 3 to 15 liters per day. In nephrogenic ADH, there is enough hormone, but as the name implies, there's actually a problem with the kidneys not responding to it. So this mass diuresis will lead to dehydration and then increased serum osmolality. And then under normal circumstances, the body responds to the decreased blood pressure and the increased osmolality by triggering the release of ADH, but in these patients, it just doesn't occur that way. So diabetes insipidus is caused by a variety of issues, including problems with pituitary tumors or trauma, or other problems with the pituitary or hypothalamus. Certainly surgery in this area or the area of the pituitary can cause problems. Diabetes insipidus can also be caused by alcohol use and also with certain medications like glucocorticosteroids. And it can also be caused by psychogenically actually just drinks really large quantities of water or has this extreme thirst, but there's really
no problem, like they don't have the disease, they don't have diabetes insipidus, they just drink tons and tons of water. So that's a psychological type of problem. And then, as we've already discussed, nephrogenic, where
there's enough ADH, but the kidneys are not responding to it. Nephrogenic problems tend to occur mostly in males and is believed to be inherited or acquired. Signs and symptoms of diabetes insipidus include polyuria and then polydyspnea, so extreme thirst. They can also have nocturia. Their urine would be really dilute, so the urine-specific gravity would be lower. Dehydration, so they could have hypotension, poor skin turgor, and weakness. And then hypovolemic shock when balance is not restored. They can also have decreased levels of consciousness and death. So the dehydration and electrolyte imbalances will lead to a decreased level of consciousness. And then if the problem is not corrected, then death. So diagnosis is based on a history of symptoms reported. Specific gravity of the urine will be less than 1.001, and then urine and plasma osmolality are compared. Sodium levels may be normal but appear elevated in relationship to the decreased amount of water. CT or MRI scans may show like pituitary tumors or something like that. And then water deprivation test. In this test, the patient is given water. Is not given water for a 6-hour period, and then during that time they'll do hourly measurements of urine osmolality, and then body weight are done too. Diabetes insipidus would be suspected if the urine continues to be dilute and the patient continues to drop weight from fluid loss even though the patient's not drinking. So the patient is then given an injection of antidiuretic hormone to see if the kidneys respond, or if the problem is nephrogenic. And then ADH levels can also be tested. This is done by looking at urine or plasma after a fluid restriction, and then infusion of a hypertonic solution. So a normal response would be an increase in ADH levels, so they'll check those as well. So treatment, they'll be given hypotonic IV solutions, and this is to replace intravascular volume without adding excessive sodium to the mix. Hypophysectomy, if a tumor, so removal of the pituitary gland. They also can be given IV or sub-Q vasopressin or intranasal DDAVP as ADH replacements. There's also a drug called Diabetes, which can be given to help the kidneys respond better to the ADH. And then thiazide diuretics, if it's nephrogenic, even though these drugs are used to increase urine output, in cases of non-nephrogenic diabetes insipidus, they can decrease urine flow. So they can be given if it's non-nephrogenic, okay? So nursing diagnosis include risk for a fluid volume deficit related to failure of the regulatory mechanisms, or risk for ineffective health management related to deficient knowledge or knowledge deficit. So now we'll talk about SIADH, and again, SIADH is syndrome of inappropriate antidiuretic hormone, and here there is too much ADH causing fluid retention and overload. So the fluid overload causes a decrease in serum osmolality, and the blood becomes dilute. This also can lead to a delusional hypernatremia. Delusional hyponatremia. When the body is functioning normally, the decrease in osmolality would trigger the inhibition of ADH or stop the secretion of ADH, but with the SIADH, this does not happen, so antidiuretic hormone continues to be secreted, making the problem continue to get worse and worse. So some of the causes, so pancreatic and some types of lung cancer can be sites for ectopic production of antidiuretic type substances. Certain drugs such as antidepressants or some types of antidepressants, some types of chemotherapy agents, and some drugs used for general anesthesia may also cause SIADH. Any issues in the brain causing pituitary malfunction, such as a tumor or infection, can also cause SIADH. And then complications from treatment of diabetes insipidus can also be the cause for this disorder. So remember, when we're treating one, that pendulum can swing to the other side and create the other. So we have to be really careful about that. So here you'll see all the signs and symptoms of fluid overload. So weight gain, usually without edema. That dilutional hyponatremia, so again, sodium levels may be normal, but in this case they appear to be low because of the excess fluid. Serum osmolality will be less than 275. You'll have concentrated urine because the water is not being excreted. And then muscle cramps and weakness because of electrolyte imbalances. Because the osmolality is low in the blood, fluids may leak out of the vessels, causing brain swelling. And if this is left untreated, this can lead to confusion, lethargy, seizures, coma, and then death. So some of the diagnostic tests, serum and urine sodium, and then also serum and urine osmolality are tested. Serum ADH can also be tested and will be high. So the normal range would be 0 to 4.7, but in this case it will be elevated. Radiological studies may be done to identify tumors, and then also a water load test could also be done, but because this can cause an unsafe fluid overload, it is not done unless it's absolutely necessary. So with a water load test, the patient is given water, then they measure blood and urine osmolality over a 6-hour time frame. The patient with SIADH will also will retain fluids instead of excreting it. So you need to identify and eliminate the causes if the problem is a tumor, and it will need to be surgically removed. Fluid restriction of 800 to 1,000 milliliters per day may also help to alleviate symptoms. Hypertonic saline or oral salts may be given to maintain sodium levels. And then finally, Lasix or declomycin may be used in cases of inoperable cancer to block the actions of antidiuretic hormones in the kidneys. So nursing diagnosis would include excessive fluid volume related to the compromised regulatory mechanisms, which may be evidenced by all of those signs and symptoms of fluid retention, so weight gain, crackles in the lungs, or low serum sodium levels. Also risk for ineffective self-health management, again, related to a knowledge deficit. So now let's talk a little bit about imbalances with growth hormone. So growth hormone is synthesized and secreted by the anterior pituitary. Problems with growth hormone can be due to problems with the pituitary gland or problems with the hypothalamus. Growth hormone is responsible for increased rate of mitosis and increased amino acid transport into the cells, also increased rate of protein synthesis, and it also increases the use of fat for energy. So all of those are involved in growth. So too little growth hormone will result in short stature, and in excess it will result in gigantism or acromegaly. So first we'll talk a little bit about deficiency. So here, deficient growth hormone in childhood will cause short stature. It used to be called dwarfism, and in adults, growth is not generally affected, but it does cause a variety of other problems in adults. This can be caused by pituitary tumor or failure of the pituitary to develop. Also, trauma to the pituitary or hypothalamus can cause these problems as well. And it also may be caused by psychosocial problems, so by severe stress or neglect or malnutrition. Malnutrition is actually the most common cause worldwide. It can also be caused by a limited gene pool. So if you take a look at box 39.2 on page 891, There's some cultural considerations, and then that will explain the issue with limited gene pool a little bit more in depth. So signs and symptoms for children with short stature, they only grow to be about 3 to 4 feet tall, but they will have normal body proportions. Sexual maturation may be slowed, and they may also have mental retardation. Other pituitary hormones may also be involved, so symptoms would depend on which of those other hormones are involved in the problem. So for adults, signs and symptoms would include fatigue and weakness, excess body fat, hypocholesterolemia, decreased muscle and bone mass, sexual dysfunction. They're also at risk for cardiovascular disease or risk for cerebral vascular disease. All of these signs and symptoms can obviously lead to a decreased quality of life. So diagnosis for deficiency of growth hormone. So the growth hormone level itself may be tested because levels are not excreted evenly. It could be, growth hormone levels can be tested, but that test may not be as reliable because growth hormone levels are not excreted evenly over the course of the day. So a hormone stimulation test could be done to measure growth hormone in response to an induced hypoglycemia. And then MRI and other radiological tests can be done to identify tumors or determine bone age or those kind of things. And then genetic testing might also be done. So for therapeutic interventions, synthetic growth hormone can be given sub-Q or IM to treat the deficiency. And then again, if a tumor is present, it may need to be surgically removed. So nursing diagnosis would be risk for ineffective self-health management, and this would be related to a knowledge deficit. And we would expect or have the expected outcome for the patient to have the knowledge about the disease and then be able to manage self-care. So on the opposite side of the spectrum, when we're talking about too much growth hormone, that is acromegaly. And here you'll see, again, excessive growth hormone in adults. Bones will grow in width and not length. Glands, organs, and connective tissues also will enlarge. And then also there can be impairment of impaired tolerance to carbohydrates, which can lead to elevated blood glucose levels as well. This can be caused by pituitary hyperplasia, again, pituitary tumors, hypothalamic dysfunction, which can cause excess growth hormone releasing hormone. So again, that kind of cascade effect where it can be a problem either with the hypothalamus, the pituitary, or the pituitary gland. So signs and symptoms, usually the first symptom that is noticed is like a change in shoe or ring size. There's nose, jaw, and brow enlargement. Teeth may become displaced. The tongue can become really thick, causing difficulty with speaking or swallowing. There can be sleep apnea, headaches or visual changes related to tumors or tumor pressure on the brain or optic nerve. And then diabetes mellitus, because growth hormone increases blood glucose levels and causes an increased workload on the pancreas. They can also have problems with arthritis. And then sexual dysfunction, so erectile dysfunction in men, and then amenorrhea in women. They may also develop kyphosis from vertebral changes, so that kind of curved back. With treatment, the soft tissue will reduce in size, but bone growth is a permanent change. It won't get changed because of treatment. So diagnosis, they can do growth hormone levels just by a routine blood draw, and then remembering that, again, this could be not the most reliable test because of how growth hormone is excreted through the body, not continuously, so you can't really predict when it will be there and when it won't. Also, growth hormone response to oral glucose. So glucose will normally suppress growth hormone, so a large dose of oral glucose would be given, and then the growth hormone levels can be checked. And if the growth hormones continue to be released, then acromegaly would be suspected. So bone x-rays can be done too to show bone growth, and then CT scans or MRIs, again, to look for tumors. So again, the cause needs to be determined and treated. If a hypophysectomy or removal of the pituitary gland is done, the patient will require lifelong hormone replacements, and not just growth hormone, but all of those different hormones that the pituitary is responsible for. So the medications given for acromegaly are octreotide, bromocriptine, and then pegvisomant. So nursing diagnosis would be disturbed body image related to changes in appearance with an expected outcome of the patient being able to accept their new body image and then express feelings of acceptance of self. Also risk for injury related to poor eyesight, sleep apnea, dysphagia, and then expected outcomes would be for the patient to not experience any types of injuries. So if a pituitary tumor is the problem, the patient may need to have the hypophysectomy or surgical removal of the pituitary gland. Radiation can also be done, and it can be used either alone or in conjunction with surgery. The hypophysectomy is done endoscopically, and this is usually through the nose or a small incision that is just underneath the lip. So the previous slide kind of has a picture of what the hypophysectomy looks like, or the surgery kind of looks like. The scope is then passed through the sphenoid sinuses to the pituitary gland, and then this doesn't really disturb the brain. So preoperatively, teaching should include, deep breathing exercises, use of the incentive spirometer. We need to talk to them about avoiding coughing or sneezing or straining, and need to explain that these can increase pressure at the surgical site. We also want to make sure that the patient understands the doctor's explanation of the procedure. So if they don't understand the procedure, or they don't understand the risks or the benefits, we need to get the provider in there again to go back over the surgery with them or answer any questions that they might have, so that they're really clear about what to expect. And then we want to get baseline neurological assessments and then prepare them for what to expect after surgery, such as the nasal packing or the mustache dressing that they might have. Postoperative care will include serial neurological assessments. These should be done routinely. We want to monitor for neurological changes or damage. Urine-specific gravity will be done also, because the pituitary surgery, again, can cause diabetes insipidus. We want to also take care of nasal packing and that mustache dressing. We're going to talk to them or remind them again about no coughing, sneezing, blowing their nose or straining or bending, and again remind them to avoid any of those activities that would increase the pressure at the surgical site. We also want to test for and report any type of cerebral spinal fluid drainage. So this can be done by testing drainage with glucose strips, because cerebral spinal fluid contains glucose. And then hormone replacement therapy with target hormones as well, such as thyroid hormones or glucocorticoids or intranasal desmopressin or sex hormones, as again, pituitary hormones are kind of hard to replace, but we need to make sure that we're replacing all of the ones that the patient is going to need once they've had their pituitary gland removed. So patient education should include to expect a small amount of bloody drainage or mucus from the nose. We want them to avoid blowing. If they have to blow, we want them to do this very, very gently. We want them to take stool softeners to avoid straining during bowel movements, and then also they can take antitussives to help with cough. We want them to be very careful when brushing the teeth or flossing, actually brushing the teeth. They can floss or use mouth rinses until the incision heals. And then we want to talk to them about hormone replacement therapy and the need to take this exactly as prescribed. And then they need to call their doctor immediately if they have any signs and symptoms of infection, so fever or drainage, and then also signs and symptoms of diabetes insipidus, so that frequent urination and extreme thirst and those kind of things. So thyroid hormones, we've talked about this during our thyroid, anti-thyroid lecture, so this will be a pretty good review. So thyroid hormones increase the function or energy function from all food types. They also increase the rate of protein synthesis and increase cellular respiration of glucose and fatty acids, increasing metabolic rate. Their activity is really reflected in the functioning of the heart, the brain, the muscles, and virtually like every other body organ that we have. They are essential for normal physical growth, mental development, and also reproductive maturation. So a deficiency of thyroid hormone is hypothyroidism, and then in excess, it would be hyperthyroidism. So again, hypothyroidism is a deficiency of the thyroid hormone. In a primary hypothyroidism, there will be a problem with the thyroid gland itself, and not enough thyroid hormone is produced. And when with secondary hypothyroidism, there's either a problem with the pituitary, gland, and then again there's tertiary, where there would be a problem with the hypothalamus. So either there's not enough thyroid stimulating hormone secreted, but in most cases the problem with hypothyroidism is primary. So primary hypothyroidism may be caused by a congenital defect or inflammation of the thyroid gland. It can also be caused by iodine deficiency or a thyroidectomy. It can also be caused by autoimmune disorder like Hashimoto's thyroiditis, which destroys the thyroid tissue. Secondary and tertiary hypothyroidism can be caused by pituitary or hypothalamic lesions. There's also a pretty rare condition of postpartum pituitary necrosis, where the pituitary gland is destroyed following pregnancy and delivery of the infant. But that's it's really, really rare. Treatment of hypothyroidism or hyperthyroidism, again, can also cause hypothyroidism. So again, manifestations will be related to decreased metabolic rate or slowing down. So fatigue, bradycardia, constipation, mental dullness, cold intolerances, hypoventilation, dry skin and hair, weight gain, heart failure, hyperlipidemia, and then myxedema, which is a non-pitting type of edema that occurs in the connective tissues throughout the entire body. So for complications, myxedema coma, and this happens when the metabolic rate drops so low that it becomes life-threatening. And here, the patient will have decreased vital signs, decreased level of consciousness. So blood glucose drops, cardiac output drops, which then reduces perfusion to the kidneys. Non-pitting edema of the face and hands and feet will occur. And then death can occur because of respiratory failure. So for diagnosis, they'll check T3 and T4 levels, and they'll be low. Thyroid stimulating can be high in primary problems, but in those secondary problems where it's a problem with the pituitary gland, the thyroid stimulating hormones would be low. Serum cholesterol and triglycerides are elevated, and if it is an autoimmune problem, antibodies are usually present. So most patients with hypothyroidism are given synthetic thyroid hormones like levothyroxine. They're started on a low dose and then gradually increased to prevent hyperthyroidism. Maintenance doses are usually between 0.1 and 0.2 milligrams per day or 100 to 200 micrograms per day. The patient with myxedema coma is monitored very, very closely. They are intubated and placed on mechanical ventilation. They are rewarmed slowly and given IV levothyroxine to replace the thyroid hormone. Again, the underlying cause really needs to be identified so that it can be treated and stop the problem. Nursing diagnoses include activity intolerance related to fatigue, constipation related to slow GI motility, risk for impaired skin integrity related to dry skin and inactivity, and imbalanced nutrition related to decreased metabolic rate. Expected outcomes would be the patient being able to tolerate activity and participate in activities of daily living. We also want them to be able to report less fatigue, and we want them to be able to pass stool. We want their skin to remain intact and moist without lesions, and we also want the patient to be able to return to their pre-illness weight and be able to verbalize dietary recommendations. So hyperthyroidism, this is excessive thyroid hormone, and this will cause an increased metabolic rate or things to speed up. It also has an increase in the beta-adrenergic receptor sites in the body, which will then increase or enhance the activity of norepinephrine. Primary is due to the thyroid gland itself. The problem causes excess hormone to be released. And secondary occurs with excess thyroid stimulating hormone release from the pituitary, which in turn causes overstimulation of the thyroid gland. And then in tertiary hyperthyroidism, there's an excess of thyroid releasing hormone from the hypothalamus, which then overstimulates the pituitary gland to release excessive thyroid stimulating hormone, and then in turn it overstimulates the thyroid gland to secrete excessive thyroid hormone. So hyperthyroidism can be caused by autoimmune disorder, so Graves' disease. It can also be caused by multinodular goiter, toxic adenoma, thyroiditis or an inflammation of the thyroid, again, pituitary tumor and secondary types of problems. It also can be caused by synthroid overdose. So if we're treating hypothyroidism and giving synthroid, then we can cause the hyperthyroidism to happen. Radiation exposure may predispose a patient to developing hyperthyroidism. Heredity may also play a role in hyperthyroidism caused by autoimmune disorders. And women who smoke nearly double their risk of developing Graves' disease. Signs and symptoms are related to increased metabolic state and include hypermetabolic state, heat intolerances, increased appetite, weight loss, frequent stools or diarrhea, and then nervousness. Other symptoms include tachycardia or palpitations, tremors, heart failure, which can occur from the tachycardia and the resulting inefficient pumping of the heart. And the patient may also become manic or psychotic. Warm, smooth skin may also happen, and then exophthalmos in Graves' disease. So also with Graves' disease, there can be a thickening of the skin on the anterior legs, and exophthalmos can occur. Photophobia, blurred vision, or double vision may also occur. Elderly patients may not have typical signs and symptoms of hyperthyroidism or hypothyroidism, so these patients may present with things like heart failure or atrial fibrillation, fatigue, apathy, or depression. So diagnosis, there will be elevated T3 and T4s. If it's a primary problem, the SIADH level will be low, and if it's a secondary problem, it will be high. Radioactive iodine uptake test or thyroid scan can be done to determine hyperactivity of the gland or locate nodules or tumors. Thyroid stimulating immune globulin would be present in Graves' disease. CT or MRI can also be done if a tumor is suspected. And then the thyroid hormone or thyroid releasing hormone stimulation test involves the administration of thyroid releasing hormone. Then levels of thyroid stimulating hormone are measured at several subsequent time points. If the thyroid stimulating hormone levels are increased after the administration of the thyroid releasing hormone, then the problem would be with the hypothalamus. And if they do not increase or only increase slightly, then the problem would be with the pituitary gland. So thyroid storm or thyrotoxic crisis is a severe hyperthyroid state that can occur, and it is a life-threatening condition. This can happen if disease is left untreated or in those who develop another illness or stressor. It can also develop after thyroid surgery if in the patients who have not been treated adequately or adequately prepared with antithyroid types of medications. Signs and symptoms include tachycardia, hypertension, fever, dehydration, delirium, coma, and then death. And then other complications would be hypothyroidism as a result of treatment as well. So some of the therapeutic interventions, PTU or propopylthiouracil and tapazole inhibit the synthesis of thyroid hormone, so those medications can be given. Propranolol or Inderal is a beta blocker, which will relieve the sympathetic nervous system symptoms. Oral iodine can be given in high doses to suppress the release of thyroid hormone. And then radioactive iodine may be used to destroy a portion of the thyroid gland. And then, of course, if none of these things are working or the disease is really, really severe, then a thyroidectomy can be done and the thyroid gland can be surgically removed. So treatment interventions for thyrotoxic crisis or thyroid storm. So treatment is first directed at relieving the life-threatening symptoms. So the patient will be given IV fluids and cooling blankets, and this will be to cool the patient. Iodine can be given again to suppress the release of thyroid hormone. Propranolol or Inderal to help with the tachycardia and other symptom control. Acetaminophen can be given for fever. We'll want to avoid aspirin because it binds with the same serum protein as T4, freeing additional T4 into circulation. So again, avoid aspirin because this can make the problem even worse. And then we'll give oxygen because of the increased metabolic rate, which will then increase oxygen demand. So we'll want to give oxygen supplements as well. Nursing diagnoses include hyperthermia related to the hypermetabolic state, diarrhea related to increased peristalsis, imbalanced nutrition related to, again, the increased metabolic rate, disturbed sleep pattern or anxiety related to sympathetic stimulation, and then risk for injury related to that hypermetabolic state, and also eye involvement. So remember from our thyroid and antithyroid lecture, when we're using radioactive iodine, we want to limit the time that we're in the room with them and then also increase the distance. So we want to cluster care. So we are going in there not a multiple amount of times, but we go in there once and get a lot of things done. And then we want to stay as far away from them as we possibly can, but still be able to get the things done that we need to. So in the patient, again, we're going to limit time spent with patient. We're going to glove and gown. If one of the nurses is pregnant or wants to become pregnant, we want to try not to assign them to a patient that has radioactive iodine in them. We're certainly going to take precautions with their urine, emesis, and body fluids. So you'll have to look at the facility's protocol to find out what that is, but it could include like double flushing or those kind of things. And then you want to call the radiation safety officer just to talk to them about how to deal with emesis or incontinence or other issues that might come about. So at home, we want to instruct patients to avoid close contact with people for about a week. They should sleep alone. We want them to wash their hands very carefully after urinating. We want them to avoid oral contact, so no sharing utensils, cups, and things like that. We want them to drink lots of fluids, and this will help to remove the radioactive iodine from the body. And then after treatment, they need to avoid pregnancy for at least a year. And then we also want to teach them signs and symptoms of hypothyroidism because they're being treated for hyperthyroidism, or we're causing destruction of the thyroid gland with the radioactive iodine. We want to make sure that they know what to look out for because, again, when we're treating for one disorder, it can cause that pendulum swing, and then they'll have that other disorder. So they can go from having hyperthyroidism to having hypothyroidism. So we want to make sure to talk to them about that as well. So goiter, this is an enlarged thyroid gland in response to elevated TSH or in response to the autoimmune process that occurs with Graves' disease, or it also can be caused by hyperplasia. The causes include low thyroid hormones, iodine deficiency, viruses, there's genetic disorders, or goitogens, or foods or medications that interfere with the body's use of iodine. Some of the foods would include turnips or cabbage, broccoli, horseradish, cauliflower, and carrots. And some of the medications that are considered goitogens are lithium, aspirin, and sulfonamides. So signs and symptoms would include an enlarged thyroid. Swelling can be very obvious, like you see here in the picture, or the swelling could also be posterior and may not be completely obvious. If posterior swelling happens, this can cause difficulty with swallowing or breathing. The patient can have hypo or hyperthyroid, or they can actually have euthyroid. So they can have signs and symptoms of any of those things. And then again, they may have problems with breathing or swallowing if they have posterior swelling. So with diagnosis, a thyroid scan can be done to evaluate the size of the gland and determine the cause. Ultrasound may also be done and can be used for the same purpose. TSH and T3 and T4s can also be drawn to see or to determine thyroid function. So treatment interventions, you want to determine the cause and then treat it. We want to teach them to avoid goitogens. We're going to treat hypo or hyperthyroidism with medications or radioactive iodine. And then if there's a problem with breathing or swallowing, thyroidectomy might be done. So nursing care, we want to monitor these people with stridor. This is a really loud, whistling sound, and this indicates airway obstruction. And if you hear this, you should report this to the physician immediately. They may also have a swallow evaluation done, which can help with recommendations for safe swallowing. And then a dietary consult. We want to provide soft foods, which are easy to swallow, that are not goitogens. So for cancer of the thyroid gland, tumors are usually benign that are found on the thyroid gland. They're definitely more common in women. They can be caused by hyperplasia, exposure to radiation or iodine deficiency, or prolonged exposure to goitogens. So signs and symptoms include a hard, painless nodule, dysphagia or difficulty swallowing, dyspnea if there's any type of obstruction or airway obstruction. Thyroid hormones here are usually normal. They may also have difficulty breathing, persistent cough, or changes in voice if the tumor is near the esophagus or trachea. So for diagnosis, a thyroid scan will show cold spots because malignant tumors do not uptake radioactive iodine, and that's you can see the blue spot here on the slide, and that would be a cold spot. And then if it's a hot spot, it will indicate a benign type of a tumor, and then a biopsy will be done to confirm the diagnosis. So for therapeutic interventions, we can do radioactive iodine, chemotherapy, partial or total thyroidectomy, or radiation type of therapy, direct radiation therapy. Again, these treatments can be used alone or in conjunction with another treatment. So if the patient has a thyroidectomy, preoperatively we want to monitor breathing and swallowing and assess voice quality so that we can compare this postoperatively. We're going to assess their nutrition status and monitor vital signs. They're going to need iodine or antithyroid drugs to achieve a euthyroid state, and medications to decrease maybe the size and vascularity of the gland, which can also help to reduce the risk of bleeding during the surgery. So preoperative teaching, we're going to talk about postoperative care. We're going to talk to them about gentle range of motion to support the neck during position changes and how to use the incentive spirometer. And then we're going to explain to them what to expect before, during, and after surgery. Post-op, we're going to monitor vital signs and oxygen and a drain if one is present. We're going to assess for signs and symptoms of thyroid storm, so that tachycardia, fever, mental status changes. We're also going to monitor for signs and symptoms of respiratory distress because of the location of where the surgery took place. So swelling there could certainly cause problems with breathing. We're going to assess for hoarseness, which may indicate trauma to the recurrent laryngeal nerve. We're going to monitor serum calcium levels and watch for evidence of tetany. And we're going to report any abnormal findings to the RN or provider or doctor immediately. Nursing diagnosis postoperatively will include a risk for ineffective airway clearance, risk for injury from tetany or thyroid crisis, acute pain, or risk for ineffective self-health management. So complications of thyroidectomy are thyrotoxic crisis or thyroid storm, which we talked about just a bit earlier, and then tetany, which are muscle spasms, numbness and tingling, which is caused by low serum calcium levels. It can also cause cardiac dysrhythmias and muscle spasms in the larynx, which can lead to respiratory obstruction. So parathyroid hormone, these hormones increase the reabsorption of calcium and phosphate from bone to blood and increase absorption of calcium and phosphate in the small intestines. They also increase the reabsorption of calcium and the excretion of phosphate by the kidneys and also activate vitamin D. The parathyroid glands secrete parathyroid hormone in response to low serum calcium levels. So in hypoparathyroidism, there's a decrease in parathyroid hormone activity, and then hyperparathyroidism is an increase in parathyroid hormone activity. It's a mouthful. So with hypoparathyroidism, the low parathyroid hormone levels again decrease the absorption or reabsorption of calcium in the bone and decrease reabsorption of calcium by the GI tract, and then decrease reabsorption in the kidneys. So calcium stays in the bone, it's not moved into the blood, and then more is excreted from the body, and this all causes hypocalcemia. And then as the calcium level falls, phosphate levels will rise, and this will cause hyperphosphatemia. The most common causes are heredity, and then also the accidental removal of the parathyroid glands during a thyroidectomy, or other types of neck surgeries, such as the purposeful removal of the parathyroid glands, like to treat cancer. Low magnesium levels, which are common in chronic alcoholism and other nutritional problems, can also cause problems with hypoparathyroidism, because again those low magnesium levels will cause an impairment of parathyroid hormone secretion. So because hypoparathyroidism causes low serum calcium levels, there can be neuromuscular irritability and tetany. Again, tetany is the numbness and tingling of the fingers and perioral area, muscle spasms, and then again it can also cause cardiac dysrhythmias. Chronic hypocalcemia can also cause lethargy or calcifications in the brain, so you might see EKG changes. It can also cause laryngospasms or spasms of the larynx, which will compromise, and then also death. So positive
Pheochromocytoma and Trousseau sign would indicate early tetany. For Chavostex, you tap the patient's facial nerve just in front of the ear, and if the face spasms, this would be a positive sign. And then for Trousseau's, you place a blood pressure cuff on the patient's arm, and you pump it above the patient's systolic blood pressure, and then spasms will happen if spasms happen of the thumb and the fingers, this would be a positive sign. So for diagnosis, there would be low parathyroid hormone levels. Serum calcium levels are low, and then you'll see that increased phosphate levels. The positive Chavostex and also Trousseau's sign. EKG can be done to evaluate cardiac function, and then again, radiological studies can show changes in the bone or problems with tumors or those kind of things. So for therapeutic interventions, if there's an acute problem, IV calcium gluconate can be given. Long-term calcium and vitamin D supplements can be given. We can also instruct them to take or have a diet of high calcium, so things like milk, cheese, yogurt, sardines, oysters, cauliflower, green leafy vegetables, salmon, those kind of things. They can be instructed to have a diet high in those things. And then also thiazide diuretics can be used as well because they reduce the amount of calcium excreted in the urine. And then if magnesium is the problem, we'll want to replace magnesium as well. So nursing diagnosis would be risk for injury related to the hypocalcemia and tetany. The expected outcome is for the patient to remain free from injury, and then they'll be able to recognize signs and symptoms of tetany, so we'll want to teach them about that so that if it does happen, it can be recognized and then treated very quickly. So hyperparathyroidism, this is the parathyroid having overactivity, which causes that increase in parathyroid hormone to be excreted. So with too much parathyroid hormone present, calcium then will move out of the bones and into the blood. Absorption of calcium in the small intestine and reabsorption by the kidney, which will then cause hypercalcemia, so high calcium levels here. And then it also promotes the excretion of phosphate, so then we'll have hypophosphatemia. So all the opposites of hypoparathyroidism we're going to see with hyperparathyroidism. So the causes can be parathyroid hyperplasia or benign parathyroid tumor. It can also be hereditary. Secondary hyperparathyroidism can be caused by excessive secretion of parathyroid hormones in response to low serum calcium levels. Signs and symptoms will include fatigue, depression, confusion, nausea and vomiting, kidney stones as well, joint pain and pathological fractures from the removal of calcium from the bones. It can also cause gastrin secretion, which can cause abdominal pain and peptic ulcers. And then dysrhythmias, coma, and cardiac arrest that would be related to that really severe hypercalcemia. So for diagnosis, serum calcium levels will be elevated. 24-hour urine for calcium to look at the amount that is secreted in the urine over a 24-hour period. Phosphate levels will be decreased, and then parathyroid hormones will be elevated. X-rays can also be done to check for bone density because, again, the calcium is pulled out of the bone. And then nuclear scans or ultrasound can also be used to help locate the glands in the parathyroid if a parathyroidectomy is planned, so they can see where they're at so that they know where to go to retrieve them. So therapeutic interventions, they'll have IV normal saline to dilute calcium and to hydrate the patient. Furosemide or Lasix can be used, and this is to increase the excretion of the calcium in the kidneys. Calcitonin or aldosterone to prevent calcium release from the bones. And then estrogen therapy for women. And then they may need to get, again, if all of this stuff is not working or it's a really severe case, they may have to get a parathyroidectomy. So nursing diagnosis, risk for injury, fracture, complications of hypercalcemia. And the expected outcome would be for the patient to remain free from any types of injuries. So for hormones of the adrenal medulla, these hormones are epinephrine, and norepinephrine. So epinephrine will increase heart rate and force of the contraction. It also will dilate bronchioles and decrease peristalsis and increase conservation of glycogen. It also vasodilates the skeletal muscle and vasoconstriction of skin and viscera. And it also increases the use of fats for energy and increases the rate of cellular respiration. So all of those fight or flight types of things that come about. And then norepinephrine causes vasoconstriction in the skin, viscera, and then skeletal muscle. So here you see a Pheochromocytoma. This is a really rare tumor of the adrenal medulla that can cause hypersecretion of epinephrine and norepinephrine. So because hyposecretion doesn't really cause a whole lot of problems, your book really just focused on problems with hypersecretion of epinephrine and norepinephrine. So with Pheochromocytoma, these tumors originate from the chromaffin cells of the adrenal medulla, which secrete epinephrine and norepinephrine. They are usually benign. The cause is really unknown, but it is found that about 5% of them are hereditary. So signs and symptoms, again, when we look at those fight or flight types of things, so hypertension, tachycardia, palpitations and tremors, diaphoresis, anxiety, hyperglycemia because catecholamines inhibit release of insulin from the pancreas, and then headache, visual changes, risk from stroke or risk for other organ damage, which is related to the uncontrolled or unstable hypertension. So diagnosis, 24-hour urine for the metanephrines, and then also vanillamindelic acid, or VMA, which are all or are both end products of catecholamine metabolism. We want to instruct the patient not to have any caffeine or medications before they do this test. And then they can do a CT or MRI to find tumors, or if any of the results are elevated, they may go to radiological types of studies. So therapeutic interventions, they may be given beta blockers like propranolol or Inderal, and that's to block the beta adrenergic receptors in the heart and lungs, which will then reduce that fight or flight symptoms. Alpha blockers, which will dilate the blood vessels to control hypertension, the acute hypertension. And then they may have to have an adrenalectomy, where they remove one or both of the adrenal glands. After surgery, if the adrenal glands do have to be removed, the patient is then at risk for hypo or hypertension, hypoglycemia. So the patient will need to have vital signs and BGs checked pretty regularly. If both adrenal glands are removed, then they'll definitely require some type of hormone replacement therapy. So nursing diagnosis, there will be risk for injury related to hypertensive crisis. So we want to monitor vital signs. We want to keep a really calm, quiet environment. We definitely don't want to give the patient any type of caffeine or any type of stimulant that may exacerbate the symptomology. And then we'll do replacement of corticosteroids postoperatively. The expected outcome would be for the patient to remain free from injury related to the hypertension. So adrenal cortex hormones. So the hormones of the adrenal cortex are aldosterone and cortisol. Aldosterone will increase the absorption of sodium ions by the kidney to the blood. It also increases excretion of potassium ions by the kidney in the urine. And then cortisol will increase the use of fats and excessive amino acids for energy, and they will also decrease the use of glucose for energy, except for in the brain. Also increases conversion of glucose to glycogen in the liver, and then also has an anti-inflammatory effect. It will stabilize lysosomes and then block the effects of histamines as well. So hyposecretion will be Addison's disease, and then hypersecretion is Cushing's disease, and we're going to talk about each one of those separately. So Addison's disease or adrenal insufficiency, so this happens again with hyposecretion of all those hormones of the adrenal cortex, so aldosterone and cortisol, and then also androgens. So primary, here the adrenocorticotropic hormone, or ACTH, can be elevated, and this is in an attempt to stimulate the adrenal cortex to synthesize more hormone. And then in secondary, there's deficient ACTH, and it fails to stimulate the adrenal steroid synthesis. Usually the adrenal gland is atrophied or small or misshapen, and it will be unable to produce adequate amounts of hormones for the body. So causes, it could be an autoimmune problem, so again it destroys itself. Usually it's in response to some type of viral infection or other type of infection. Can be fungal infection. It also could be infection related to AIDS. Cancer can also cause this problem. And then problems with the pituitary or hypothalamus can cause secondary adrenal insufficiency. And then another thing that can cause Addison's disease is the abrupt discontinuance of steroids, especially after long-term use. These patients are really at an increased risk for adrenal insufficiency or Addison's, and that's because the pituitary has been suppressed for such a prolonged period of time that it can take it a really long time, like up to a year, for ACTH to be produced normally again. So low aldosterone levels cause sodium and water to be lost and retention of potassium. So the result is like tachycardia and hypotension. Low cholesterol levels cause hypoglycemia, weakness, fatigue, weight loss, confusion, and psychosis. Again, if we don't have the energy for our brain, it does not work properly. In primary adrenal insufficiency, the increased ACTH may produce a bronze appearance to the skin from hyperpigmentation. It can also have electrolyte imbalances, which can cause nausea, vomiting, anorexia. And then the low androgen levels may cause women to have decreased amounts of body hair. So diagnosis, serum and urine cholesterol levels or cortisol levels will be checked. Blood glucose will be checked. It's usually low. Electrolytes will also be monitored. A BUN and hematocrit will be elevated because of the dehydration. Again, that hemo concentration. ACTH stimulation tests can help to determine if the adrenal glands are functioning. And then CT MRI, those type of radiological types of studies can also be done, again, to evaluate the size of the gland or locate a tumor if there's some type of secondary disease going on. So complications, here we'll talk about adrenal crisis, and this can happen if the patient is exposed to stress. So the stress can be from infection or trauma or even psychosocial types of pressure. The body is unable to secrete cortisol normally, causing a loss of large amount of waters and sodium, or water. And if we lose a ton of our fluids, then profound hypotension and tachycardia and dehydration can happen. And then potassium is retained, and then we get hyperkalemia, and this can cause cardiac dysrhythmias. And then hypoglycemia can also be severe, so low blood glucose levels. Certainly, if treatment is not initiated quickly, the person will experience shock, coma, and death. To treat adrenal crisis, fluids are given, and then also cortisol is replaced. Fluids will contain glucose, and then large doses of glucocorticoids are also administered, and then electrolytes are replaced as well. And then, as usual, we certainly need to figure out or identify the cause of the problem, and then treat it to fix the problem. So therapeutic interventions, glucocorticosteroids, or glucocorticoids, or mineral corticoids will need to be taken daily. So the person will need hormone replacement therapy probably for the rest of their life, depending on the problem, or if they have one adrenal gland or none. Treatment will include these medications where they'll take 2/3 of the dose in the morning and then 1/3 at night, and this mimics our normal body's release of these types of hormones. If the problem, or if the person experiences any type of stress, then these dosage may need to be doubled or tripled, because naturally these hormones are elevated in times of stress. And they may also be placed on a high sodium diet. So nursing diagnosis will include a risk for deficient fluid volume related to deficient adrenal cortical hormones. Also a risk for ineffective self-health management related to knowledge deficit about self-care of Addison's disease. And then the expected outcomes are for the patient to have stable fluid volumes, stable weights and vital signs, and normal skin turgor. We want the patient to be able to verbalize signs and symptoms of adrenal crisis, and have an understanding of self-monitoring and self-medication at home. So again, we never want to stop patients that are taking steroids abruptly, because that can cause this Addison's or adrenal crisis. Again, a patient receiving long-term corticosteroids are at particular increased risk for adrenal insufficiency if the drugs are discontinued abruptly. So we don't want to do this because we don't want to get them into a crisis type of situation. So Cushing syndrome, here there is excess adrenal cortex hormones, so cortisol, aldosterone, and androgens. Secretion of these hormones are usually increased during times of stress, as discussed already. They're also higher in the morning, naturally. Again, that's why when we're doing replacements, we give the higher dose in the morning and the other part in the afternoon. And with Cushing syndrome, cortisol is hypersecreted without regard to the time of day or stress level. So it doesn't matter if it's morning, night, if there's no stress at all, there is still an abundance or hypersecretion of these hormones. Effects of excessive aldosterone and androgens will also be seen, because again, those are the other hormones for this gland. So Cushing's can be caused by a hypersecretion of ACTH by the pituitary. usually from a benign pituitary adenoma, hypersecretion of cortisol, and this can be from adrenal hyperplasia or problems with the adrenal glands, such as adrenal adenoma or carcinoma. Can also be caused by prolonged use of exogenous glucocorticoids, and this is actually the most common cause. These types of medications are usually given to those folks that have like COPD or Crohn's or other chronic types of inflammatory disorders. And then ACTH can also be produced ectopically by tumors in the lungs or other organs as well. So most of the signs and symptoms of Cushing's are related to excessive cortisol. So you'll see salt and water retention related to the mineral corticoid effect. And then hypokalemia from the loss of potassium in the urine. You'll see thin, fragile skin, and then that purple striae, usually on the abdomen, buttocks, or breasts. Fat pads can develop on the upper back. This is called a buffalo hump. The face can also become very rounded or moon-shaped. Cortisol can also cause insulin resistance. So secondary diabetes mellitus can also develop. There also can see androgen effects, so acne, facial hair in women, or amenorrhea. And then effects on the bone can also cause things like osteoporosis or pathological fractures. And then remembering, because cortisol has an immune suppressive action, they're also at an increased risk of infection. So the initial diagnosis may be really based just on the appearance of the patient. So they'll have like that Cushingoid type of appearance. So you saw the picture on the previous slide. It's much like that. Plasma or urine cortisol levels. So a 24-hour urine test can be collected to check for cortisol levels. Potassium levels can also be measured to monitor for hypokalemia. Then again, CT or MRI can be done to look for or to look at the structure of the glands or to locate tumors. And then dexamethasone suppression tests. So here, the level of cortisol in the body is usually regulates the release of ACTH from the pituitary gland. And as blood cortisol levels increase, ACTH release will decrease, and so the inverse is also true. So as the cortisol levels decrease, ACTH will increase. So dexamethasone, which is a synthetic steroid that is really similar to cortisol, will be given. So in a normal functioning person or body, if dexamethasone is administered, it will reduce ACTH release. So taking the dexamethasone, again, should reduce the ACTH levels and then lead to decrease in cortisol levels. So this test can be done with different types of dosaging. So they do it with standard dosages, low dosages, or high dosages. And then, again, they're used to see how the body responds to diagnose the Cushing syndrome. So therapeutic interventions, surgery would be done to remove a pituitary tumor if this is the problem. They certainly can reduce dosage of steroids or change the schedule of administration if steroids are the cause. They will also do some treatment around symptom control. They may also need surgery to remove the adrenal gland if there's a problem with the adrenal gland itself. Diabetes treatment will also be done, so monitoring blood glucose levels and then medications to help control those may also need to happen. There's also a drug called ketoconazole, which can be given, and this blocks the production of adrenal steroids, so that may also be given as well. And then they'll might be started on a low sodium or high potassium diet. So nursing diagnosis, here you're going to see risk for excessive fluid volume, and this is related to the sodium and water retention. Risk for impaired skin integrity related to thin, fragile skin. Risk for infection related to immune suppression, or risk for unstable blood glucose levels related to impaired glucose tolerance, or body image disturbances related to the Cushingoid appearance. So the expected outcomes would be for the patient to maintain stable daily weights and for the skin to stay intact. The patient would remain, we want them to remain free from infection, and we want their blood glucose levels to remain within normal limits. Then for body image disturbance, we want the patient to be able to express feelings of acceptance for themselves. Then if a patient has to have an adrenalectomy or removal of the adrenal gland, preoperatively we want to monitor electrolytes and glucose. Abnormalities will need to be corrected before the surgery to prevent adrenal crisis. They may also get glucocorticoids. I cannot say that for some reason. Sorry, guys. Can also be administered to help prevent adrenal crisis. Preoperatively, again, teaching needs to be regarding the type of surgery and what to expect. The use of the incentive spirometer, and again, techniques to ensure that we don't increase any type of pressure, especially if they are having their pituitary gland removed also. So no coughing, sneezing, blowing nose, that kind of stuff. And then if they have an adrenalectomy, we also want to talk to them about splinting techniques as well. Postoperative care, we're going to monitor for signs and symptoms of adrenal crisis, and then lifelong hormone replacement therapy. So they'll need to be monitored closely after surgery for changes in fluid and electrolyte balance and for signs and symptoms of adrenal crisis. And then again, if both the adrenal glands are removed, they may need that lifelong hormone replacement therapy. If only one of them is removed, then it's very possible that they may not need the hormone replacement therapy. It just depends on whether the other gland is able to produce enough hormone for adequate body function. So that's the end of this lecture. Again, if you have any questions, you can post questions on the discussion forum under the questions section. You can email me or text me. And of course, you can always make an appointment to discuss any concepts that you don't understand.